First, I would like to thank the organizer for inviting me to give this talk, and I would like to thank all the audience for giving me the time to listen to my research over the past year that we have done in the lab. So as you know, our field started in 1958 by John Doucet when he was mixing the serum from people who has been multiple transfused with the cells from another individuals, and he noticed that sometimes these cells get agglutinated and sometimes not. And because of this discovery, he focused that there must be some sort of alloantibodies present in these patients' serum that are recognizing an antigen on the cells. Now we know that this is the HLA antigen. So his phenomena actually raised the idea that people are forming HLA antibodies against the antigen. Like for example here, you can see this antibody is formed against the A1 antigen, this antibody is formed against the DR7 antigen, and this antibody is formed against the CW9 antigen. However, this is not true because antigen does not, or antibody does not recognize the antigen. Antibody recognize specific parts of the antigen that we know about, which is called the epitopes. So for example, here you can see there are multiple epitopes on this class 1 antigen, and you can see that this specific antibody recognizes only one specific epitope, and it's the same idea of the lock and key phenomena. So we started our research by recruiting 616 patients who has been transplanted in the time between 2012 up to 2022. And we looked and we monitored them for the developing of donor-specific antibody. And our hypothesis was built that the molecular Eplet mismatch outperformed the conventional antigen mismatch in risk assessment of these patients. And this is briefly the idea of our hypothesis. Like for example here, if you have a donor who is typed as B18, and the patient is B7, HLA B7. So now the patient will see that the B18 as one antigen mismatch, but in real life, the patient will see 11 different epitopes that are not shared between the patient and the donor. So now the patient will see this as mismatched epitopes or 11 epitope mismatch. But in real life, if you see the whole typing of the patient, and the patient is B52 and A33. Now, if you look at the combination of these three alleles, you will see that they are actually matching the donor in this epitope. So in real, so although the patient and the donor has one antigen mismatch, which is the B18, but there is no epitope mismatch. So there is unlikely that this patient will develop any antibodies against the B18. And this was basically the hypothesis of our research. So we looked at this 616 patient, and we found that during the monitoring phase that 106, which represent about 17% of these patients, developed donor-specific antibodies. And the majority of the donor-specific antibodies was directed against the DQ, and then the next one was against the HLA antigen. So here we started to look at the number of epitope mismatch between the donor and the recipient. So for example here, if we look at the number of HLA mismatch at locus A, and here we divided this group of patients into group 1 and group 2, and group 1 means that they have actually one antigen mismatch, and group 2 means they have two antigen mismatch, and we removed the group that has zero antigen mismatch to avoid any bias. And every single dot here, what you see in the graph, is representing one patient. So if we look here at this patient here, you can see that this patient has one antigen mismatch at the locus A and have almost 20 epitope mismatch. But here, if you look at this patient has two antigen mismatch and has even less epitope mismatch than the group that have one antigen mismatch. So it's very clear that epitope mismatch is going to give you a more crispy or more high resolution idea on the risk assessment of these patients. And we conducted all this with all the other loci. The next phase of this experiment, we wanted to identify a cutoff because we need to give the nephrologist something that they can use it as a risk assessment. So we started to do what we call ROC curves. And here we looked at the sensitivity versus specificity of each locus. And based on this ROC curve, we were able to identify a cutoff for each epitope mismatch. And here is the cutoff of all single locus. So you can see here, like we are saying that this patient, if they have more than 15 epitope mismatch, they have a high risk of developing a donor-specific antibody against the A. And if we look here at the DQ, you can see that if these patients have more than 9 epitope mismatch, they are more likely to develop donor-specific antibody against the DQ. And we looked at the graft survivor over years, and using this risk stratification, we were able to classify the patient into 3 different groups. Low risk, which is the 0 mismatch, and these are the people that did not develop any donor-specific antibody, and the graft was still surviving. And then patient who develop medium risk, who has between 1 to 14 mismatch, and patient who have high risk, who have more than 15 epitope mismatch. And the same scenario happened in the DQ. And if you can, from the death sensor survival, you can clearly see that these patients were able to develop donor-specific antibody when they have higher epitope mismatch. And now we implemented this clinically in our lab. So this is our report. So you can see here, the top here is we have the patient typing, and we do all the typing by high resolution. And in the bottom here is the donor typing. So if we are using the conventional antigen mismatch, you can see we give them the score of 2 for the A, score of 2 for the B, and 1, and so on. But when we switch to the epitope mismatch, you can see that these numbers has been changed here. So now this patient has 19 epitope mismatch, which means that they have higher risk of developing donor-specific antibody. And here, if you look at this, what I found it very interesting, because if you look at the DR beta 1, although they have one conventional antigen mismatch, it actually have 0 epitope mismatch. So this patient is unlikely going to develop any donor-specific antibody against the DR beta 1, and the picture has been reversed in the DR beta 3. At the end, I would like to conclude my talk, but epitope mismatch can replace the traditional antigen mismatch for predicting donor-specific antibody, rejection, and graft survival. Epitope matching may be a useful tool for organ allocation and post-transplant care decision, and it could be a way for personalized medicine, but it requires more knowledge for precise alloimmune risk. And here is the picture on how our field started by agglutination, and now we are doing HLA Matchmaker. And before I end my talk, I would like to thank all my team in Saskatoon in our lab who did all this awesome work that made me come in front of you and present it. And without them, I will not be able to present this nice idea. Thank you, and I'm willing to answer all your questions.